All right, we'll wait a few minutes for people to trickle in here.
Okay.
Okay, looks like it's slowed down a little bit, so I'll just share my screen and we can get started, and people can trickle in as they are able to.
And just tell me when you want me to share.
Sounds good. Can you see my screen that I've shared here?
Yep.
Okay. Well, good morning, everyone. Welcome to our second monthly Stroke Month webinar. My name is Caitlin. I'm a program manager here with the American Heart Association, working in the Mission Lifeline Post-Acute Stroke Care Initiative. And my counterpart, Joni's on the call as well. She's working on the EMS and acute care side of our initiative. So I'm really happy to introduce Dr. Madson today. Before we get started, just a quick disclosure here that the opinions expressed in the webinar are solely those of the presenter and may not necessarily reflect the American Heart Association's official positions. A bit of housekeeping. Go ahead if you guys have any questions or anything or any comments. You can add them to the chat, or you can raise your hand and we can take you off mute. So we'll take questions at the end, especially if you want to talk or ask any questions. The ones in the chat we'll keep monitoring and answer as they come in if we're able to. Otherwise, we'll ask them at the end. And this is recorded and will be uploaded to our website here at actfastsd.org, so you can review and share with others. It'll be a YouTube link that you can rewatch the recording. So without further ado, welcome to Dr. Brooke Madson. She's a board-certified physical medicine and rehab specialist at Sanford Health in Sioux Falls. She completed her PM&R residency in Louisville, Kentucky, where she served as chief resident. She's since returned home to South Dakota as a staff physiatrist in the same inpatient rehab unit where she volunteered in high school. So she's come full circle. And she is serving as the co-medical director of the Sanford Physical Medicine and Rehab Department, and is a clinical assistant professor for the Sanford School of Medicine. So welcome, Dr. Madson. Thanks for joining us today.
Well, absolutely. Thank you for the introduction, Caitlin, and I'll share my screen if that's okay.
Perfect. Yep.
Well, welcome everyone, and thank you for listening and taking time out of your lunch hour. It's my pleasure to be included in this series, and I will be giving the post-acute stroke care talk today, and we're taking it from a physiatrist's approach. So we'll start. I have no financial disclosures. I'm going to give this talk in kind of two parts. The first part being what is physiatry, and then our approach to stroke care. So PM&R, it's the specialty of many names, and it's often confusing. So I thought I would go over a little bit about who we are and what we do. From the American Academy of Physical Medicine and Rehabilitation, this is how they describe our field. Physical medicine and rehabilitation, PM&R, also known as physiatry or rehabilitation medicine, aims to enhance and restore functional ability and quality of life to those with physical impairments or disabilities affecting the brain, spinal cord, nerves, bones, joints, ligaments, we're going to keep going faster here, muscles and tendons. A physician having completed training in this field is referred to as a physiatrist. Unlike other medical specialties that focus on a medical cure, the goals of the physiatrist are to maximize patients' independence and activities of daily living and improve quality of life. How do we become physiatrists? First, like any other specialist or physician, we go to 4 years of medical school. And then from this avenue, it's where our training differs. When I was going into my training, most programs were advanced programs, meaning that you went and you did an intern year, whether that was a transitional year or a preliminary year in surgery or medicine, and then you went on to do your advanced PM&R program, which was 3 years in duration. Now, more and more programs are starting to transition to categorical programs. So incoming resident will go to one location for all 4 years of their training. A physiatry residency includes rotations in inpatient rehab, PM&R clinic, pediatric inpatient rehab and clinic, cancer rehab, amputee clinic, pain medicine, pulmonology, sports medicine, neurosurgery and orthopedics, electrodiagnostics, and many more. We can then go on to specialize after completing a fellowship. Fellowships include cancer rehab, traumatic brain injury, spinal cord injury, electrodiagnostics, sports and spine, pain fellowships, pediatric fellowships, and that's the only physiatry residency that is a 2-year program. And then we can also go into palliative care or research. Who do we serve? We serve patients both inpatient and outpatient, and kind of like I described in the conditions that we treat as physiatrists, our inpatient population are typically patients that have functional deficits related, but not limited to, spinal cord injuries, traumatic brain injuries, strokes, multi-traumas, debilities, CP, and more of the pediatric population, amputations or burns if you're in a burn center. Our outpatient patient population, we include all of those that we see on inpatient, but then you might see physiatrists performing more musculoskeletal care, and then you might see them in a multidisciplinary clinics, such as ALS, polio, or a CP clinic. We're also very involved in adaptive sports. Where do we practice? We practice in both adult and pediatric scenarios. You'll see us in PM&R clinics. You'll see us, like I said, in the multidisciplinary clinics, and then you'll see us in acute inpatient rehab. When you think of an acute inpatient rehab, you can have freestanding rehabilitation centers, or you can have rehabs that are in a hospital. Here at Stanford, we have a 21-bed unit with 24/7 coverage provided by 2 physiatrists and 1 nurse practitioner. You also see us in the hospitals doing consults, whether it be on the ICU or just general floors. You'll find physiatrists in skilled nursing facilities, LTACs, and working with university athletic facilities. What do we do? In the clinic, we're doing our hospital follow-ups, and we're also seeing new patients. We might be doing some procedures, some DME prescription, or therapy prescription. Procedures that we're all trained in residency include epidurals, medial branch blocks, fluoro or ultrasound guided joint injections, trigger point injections, electrodiagnostic studies, baclofen pump management, Botox or phenol injections, and sometimes we're even removing trachs or pegs. We all have this training. It's just dependent on the physician, what they do in this scope. Most pain procedures are now performed solely by those who have done pain fellowships. You can find us in the ORs performing electrodiagnostics for surgical procedures, or we might be doing Botox or phenol injections under sedation for children who can't tolerate being awake. We're writing DME prescription, like I said, for mobility, for ADLs. We're writing for orthotics and prosthetics, bracing, for stair lifts or home adaptions, and then we're working with sports adaptive prescriptions as well. And then we're writing for therapies as well, with emphasis on certain modalities such as E-stim, K-taping, dry needling, or traction. Inpatient rehab is where a lot of my time is spent. And the goals of an inpatient rehab unit are to address patient impairments, to improve function, safety, quality of life, and promote independence. We provide patients and their family or social support with education regarding their condition, regarding their safety, and how we need to assist them to become more functional. We also, a huge goal of ours is to discharge patients to their homes as opposed to another facility. The rehab team is very much a team sport. And we have many different people included, and you can see some of them here. You have myself, a physiatrist, and I'm reviewing and determining appropriateness of patients for inpatient rehab. I'm providing monitoring, assessment, and management of both medical and functional problems. My whole goal is to maximize a patient's capacity to benefit from and tolerate and really succeed in our inpatient rehab program. We have nursing available 24/7. They are working on administration of medications, providing skincare, pressure relief, monitoring, and education. In our facility, we have PT, OT, speech, and therapeutic rec, and they are working on addressing mobility, functional goals, and cognitive impairments. They're also addressing equipment needs and home modifications. And a key portion about inpatient rehab is the degree of therapy that they receive. They're receiving 3 hours of therapy a day, at least 5 days a week. We have both social work and case management. We have a dietitian involved. I have an intake coordinator. And at certain locations, we might even have integrative therapists or pet therapists that are also involved. Before a patient is able to come to inpatient rehab, each one needs to be reviewed by a staff physiatrist. I have an intake coordinator who assists me with this, and we sit down and every consult is reviewed. We review referrals from acute hospital, LTACs, clinics, or home. An example of someone who might be referred from home would be someone with a progressive spinal cord condition who are now becoming paraplegic, and they need that training on a neurogenic bladder or bowel program and adapting to wheelchair mobility. We're reviewing for 13 rehab diagnoses. However, I will say traditionally we had these 13, but we will take diagnoses outside of this scope. I won't go over each one, but as we look at those, these are all conditions that greatly impair patients' function. The majority of patients I see are spinal cord injuries, traumatic brain injuries, strokes, and major multi-trauma. If you're interested more in those rehab diagnoses or how we are paid, you can go to the link for the Medicare inpatient rehab payment system. But the other things I'm looking for when I'm debating if a patient is appropriate for inpatient rehab is I'm looking at their medical needs, their complexity, and stability. In order to come to rehab, I need a patient to be medically stable enough where they can participate in 3 hours of therapy a day, but they need to be complex enough to require 24/7 physician availability. I'm looking at their prior level of function. If the patient was dependent prior, a course of rehab is likely not going to get them far from their baseline if they were dependent in all cares before. I'm also looking at participation in and tolerance of therapies. If a patient is saying, I don't want to do my one physical therapy session a day, 3 hours is going to be too much. I also need to make sure that a patient is able to tolerate them. If blood pressure is limiting, if fatigue is limiting, and they're only able to tolerate 15 minutes a day, and it doesn't seem that this is improving, inpatient rehab might not be the best option for them at that moment. I'm also looking for their discharge plan, who's going to be able to help them when they go home. I'm looking at if they have, 14 stairs, are they even going to be able to get into their home? And then I'm looking at their functional needs, which we're going to look at more here. When I'm looking at functional scores, I'm using this FIM instrument, and we're going to go ahead quick. And I want to go over this so that you can decipher what some of these therapy notes are telling you when you see them. The FIM score is a uniform scale of measurement for disability based on the International Classification of Impairment, Disability, and Handicaps. What we're going to focus on are the tasks rated on that 7-point scale because you'll see some of this language in the therapy notes. I want to say that function can also be measured with the modified Rankin scale and disability with the Barthel index. So when we look at the FIM instrument, I think it is important to note where it says that there's a helper involved and where there's not a helper involved. When we look at this, we think of a patient of total assist. The patient is able to do less than 25% of the task. If you see a patient is ambulating 2 feet with max assist of 1, that means that the patient is able to do about 25% of the work, and our staff is doing about 75. Moderate assist means the patient is doing about half of the work themselves. If I see that a patient is ambulating 250 feet with min assist and a front wheel walker, that tells me that they're only needing about 25% help. Then we can go down if they're just requiring supervision or cues for safety. We also have modified independence, or you might see it abbreviated to MOD-I. This means they're using it with some type of adaptive equipment, but they're able to do it themselves. You'll also see terms such as contact guard assist, standby assistance, or just with setup. And when you read these therapy notes, it's telling me how much help they need. The other thing I'm considering when I'm going through their therapy needs, their complexity, is where these patients should go following discharge from the hospital. Below are some of our main discharge locations, and this is what I am considering for each patient. We'll start out with inpatient rehab here on the right. If a patient is going to go to inpatient rehab, they're going to have 3 hours of therapy a day, at least 5 days a week. These patients are medically complex, they require 24/7 physician availability, and they're having daily rounding. The cost of this is understandably higher due to the degree of therapy and your physician availability and nursing staff. Patients that are ideal for inpatient rehab typically have a new alteration in function, they're medically complex, they're able to participate in intensive therapies, and like I said, they have had function impairments due to traumatic brain, stroke, or spinal cord, etc. The plan is to go home. Contrary to that, if a patient might just be standby assistance or contact guard and they're going to be able to go home sooner, or they don't have a good discharge plan, or they're not very medically complex, I might recommend a SNF. Therapy provided at a SNF is provided, but it's less intense and it's not daily. The patient is stable, a physician is available, but typically not rounding or providing as much supervision. The cost is understandably lower. So that patient population, they're not as medically complex, they're unable to tolerate 3 hours of therapy a day, and they're too functional for an inpatient rehab facility, but not safe to go home, or they just might need a longer duration of help. We also have a long-term acute care hospital. Here, therapy is provided, it just might not be daily, and it's less intense than inpatient rehab. These patients are very medically complex. They require physician availability and daily rounding, and the cost is higher. These patients are, like I said, medically complex and not able to participate in inpatient therapies. And it's because they're undergoing vent weaning, or they're minimally conscious, or just still too ill to participate. Now we're going to move on to the post-acute stroke care. And all of these are conditions that we're managing in inpatient rehab and in clinic if patients follow up with us afterwards. Per UpToDate, stroke is the 3rd most common cause of disability and 2nd most common cause of death worldwide. I'm going to just breeze through these. I know Dr. Sandhu will have his lecture next week, but just some basic deficits that we can see after a stroke. In lacunar infarcts, so in your putamen thalamus, caudate, internal capsule, you'll see absence of higher cortical deficits such as language impairments or vision, and they're typically motor or sensory. If you have an MCA territory infarct, you're going to notice, and like I said, these typically, some people are exceptions, but you'll notice deficits on the contralateral side, arm affected more than the leg. If it is a superior division infarct on the left side or dominant side, you'll notice a global aphasia or Broca aphasia. On the right side, the non-dominant side, you might have deficits on spatial perception, hemi-neglect, and dressing apraxia. In the inferior division, you might notice some of these visual deficits. On the left dominant side, a Wernicke's aphasia, and on the right side, a left visual neglect. If the ACA if that territory is damaged, you'll notice deficits on the contralateral side, leg more so than the arm, and oftentimes they have urinary incontinence. If the vertebrobasilar system has an infarct, you'll notice again absence of higher cortical deficits, but you might notice nystagmus, vertigo, cross deficits, and cranial nerve deficits. This is taken from the Physical Medicine and Rehabilitation Board Review by Sarah Cucurullo, and I think it describes our goal nicely. She states that the primary goal of stroke rehab is functional restoration by maximizing the independence, lifestyle, and dignity of the patient. This approach implies rehabilitative efforts from a physical, behavioral, cognitive, social, vocational, adaptive, and educational point of view. I had an attending once who told me that the emergency room staff, the neurology team, they save a person's life with a stroke, and it's the rehab team that can bring them back to life. Once patients come to inpatient rehab following their stroke, it's often here that they notice the degree of their impairments and how so many things are affected. It's also here where they often ask about prognosis and recovery. What I tell them is this: most recovery takes place in the first 3 to 6 months. Do we notice some improvement at a year? Yes. But what we're going to get back is mostly noticed in that first 3 to 6 months. Risk factors that we look for disability after a stroke would include minimal recovery at 4 weeks, decreased alertness, numerous comorbidities, older age, if they experienced a delay in medical care or rehab, if they were previously disabled, if they have poor sitting balance, severe neglect, global aphasia, incontinence lasting greater than 1 week, poor social support, or a lower socioeconomic status. When I think of predictors of recovery, poor prognostic indicators would be if at onset there was complete paralysis. That often leads to a poorer prognosis of useful hand function down the road. Approximately 9%, though, that had complete paralysis and slow gain of recovery will have good recovery in the long run. If we notice late return of proximal traction response, so your shoulder flexors and adductors, more than 13 days, that's also a poor prognostic indicator. If at 4 weeks, though, we do have some motor recovery of the hand, there's up to a 70% chance of making a good recovery. So we'll go on and we'll just kind of go through a variety of conditions related to stroke now. And the first will be hemiparesis. Up to 88% of acute stroke patients have a degree of hemiparesis. 60% of patients will have upper limb deficits after 6 months. And hemiparesis yields a direct increase in healthcare costs. Medicare cost per stroke patient, with hemiparesis over a 4-year period was $77,000 and $53,000 for those without hemiparesis. And the cost in terms of quality of life for these patients is also tremendous. We are briefly going to cover some patterns of recovery so we know what we're looking at as patients recovery. Or as they recover, The first is the Twitchell pattern of motor recovery following stroke and resultant hemiplegia. And these are taken with MCA distribution stroke. You'll first notice total loss of voluntary movement and loss or decrease in deep tendon reflexes. Around 48 hours later, we might notice increased reflexes on the affected side. And then we'll notice the development of tone that might lead to spasticity. In the upper extremity, we talk about a flexor synergy pattern. So you're noticing tone in the flexors and adductors. In the lower extremity, we have extensor synergy patterns where you're noticing tone in the extensors and adductors. And then between 1 to 38 days, clonus may appear if spasticity is present. Recovery of movement occurs proximal to distal, and with increased movement, there's often decreased spasticity. And like I said, this trend doesn't apply to everyone. The other pattern of motor recovery is the Brunstrom pattern. Here again, you notice flaccidity first, then spasticity will appear with those basic synergy patterns emerging, but here they have minimal, if any, voluntary movement. As the patient gains voluntary control over synergies, we'll notice that spasticity will peak. And then we'll notice some movement patterns outside of the synergistic patterns. Remember, I said synergistic patterns are flexor in the upper and extensor in the lowers. And then they'll notice more complex movement combinations being learned. Hopefully, Spasticity will resolve. However, that's not the case for many patients. And if everything goes according to plan, they will have normal function. However, unfortunately, we don't see return to normal in every patient. We have numerous rehab methods for motor recovery, and I'm not going to go into depth on any of these because they would be a talk in themselves. My therapists and therapists anywhere are, doing the ton of work here with these, and they're helping the patient immensely. They're also utilizing a variety of these methods. They're utilizing proprioceptive neuromuscular facilitation, so using spiral and diagonal movement. This bow bath technique is a technique where therapists are trying to normalize tone and inhibit primitive patterns of movement. So don't use those flexor synergies. It's a very common technique. You also have the Brunstrom method, so using your primitive synergistic patterns. You have the sensory motor approach. It's a modification of motor activity and muscle tone by using cutaneous sensory motor stimulation. And you can also work just on motor relearning functional movements and problem-solving techniques. We have constraint-induced movement therapy. This is where you might notice that a patient has at least 10 degrees of wrist extension and finger flexion on the affected or hemiparetic side, but they might have a mitt on their fully functional side, encouraging them to try to use that side that's been affected by stroke. We can also use functional electrical stimulation. A device gives electrical stimulation above the motor threshold to cause a motor contraction. It can be therapeutic or it can be functional. We're also using EMG biofeedback in some facilities, utilizing robotic devices, motor imagery, mirror therapy, or virtual reality. We can also use medications for motor recovery. In the FLAME trial in 2011, fluoxetine administration was coupled with intensive physical and occupational therapy to determine if it enhanced motor recovery. Their conclusion was that they found enhanced motor recovery at 3 months. However, other trials or other subsequent trials, the FOCUS, EFFECTS, and affinity trials, did not find that addition of an SSRI had any effect on motor recovery. We also have surgical methods for motor recovery. Right here at Stanford, we're doing the vagus nerve stimulation, and the vagus nerve is the longest cranial nerve in the body. It's a mixed nerve, so 80% is afferent and 20% efferent, and vagus nerve stimulation is already being used for epilepsy and depression. There's trials for other conditions as well that are ongoing. The thought process behind it is that a mild electrical stimulation of the vagus nerve leads to activation of the basal forebrain and locus coeruleus neurons and the subsequent release of acetylcholine and norepinephrine. This facilitates cortical network reorganization when paired with intensive therapy. The goal of this stimulation is to improve motor recovery to the arm and to the hand, and it's now being performed here at Stanford. Here is just one study that was obtained from the Archives of Physical Medicine and Rehabilitation. The objective was to determine if long-term home-based intervention using paired vagus nerve therapy is feasible and whether there are benefits. And the results here are interesting. It did show that 1 year after paired vagus nerve therapy, the Fugl-Meyer index, we'll kind of go into that different, improved by an average of 9.2 points. So they are noticing benefit. When patients come to see me in clinic to determine if they are candidates for this, there are a variety of things that I look into for eligibility. First, they have to be adults. They have to be greater than the age of 18, and they have to have had their stroke greater than 6 months ago. They have to have chronic upper limb motor deficits, and they have to have a score on a Fugl-Meyer of 20 to 50. So these patients have already been seen by occupational therapy so that I can have that score available. They have moderate to severe upper extremity impairments and no history of bilateral or left vagotomy. Candidacy, they have to be willing and able to complete Intensive therapy. About 2 weeks after they have the device implanted, they will undergo occupational therapy 3 times a week for 90 minutes. They do need to have some active movement of the wrist and digits, and they have to have spasticity that's controlled enough to allow for active therapy participation. They also have to be able to have some sensation to that limb. In inpatient rehab, we're also recommending and working with patients on a variety of equipment. We won't go over everyone here, but we're working on slide board transfers or educating a patient on a wheelchair that they can steer just with one side of their body. We're also putting them in things like you see on the right here with an arm trough on their wheelchair so that their arm doesn't lean or it doesn't fall to the side of their wheelchair and cause edema or damage to their hand if they would get it in the wheel. It also helps prevent shoulder subluxation. We're working on walkers, and then we're working on adaptive techniques for the patients to feed themselves. Maybe they don't have much grip, but they have some elbow flexion, so use of a universal cuff will help them feed themselves. We also focus on bracing, and we focus on bracing for both function and positioning. If a patient is flaccid on one side, I like to have them in a multi-potus boot or a Lennard at night to provide some subtle heel cord stretch. Or if they have tone developing in their hand, having them in a resting hand splint at night to provide a subtle stretch all night long to prevent that tone. We also are prescribing and fitting patients with AFOs for their foot drop, or maybe a humeral cuff sling because of their shoulder subluxation. Another condition we're monitoring and treating in inpatient rehab is dysphagia. Dysphagia occurs in approximately 67% of brainstem strokes, 28% of left hemispheric strokes, and 21% of right hemispheric strokes. Our video fluorographic swallowing eval is the gold standard, as aspiration is missed on bedside swallow evals in 40 to 60% of patients. If you are sitting with a patient and you notice that they're eating and then they have an abnormal cough, or they have, a lot of coughing after they eat, or they're having voice changes, dysphonia or dysarthria after eating, those might be indicators of aspiration as well. When you see diets prescribed, you'll notice different levels. So this ITSE level framework provides a common terminology for describing food textures and drink thicknesses to improve safety for individuals. The thicker the liquid, the more time the oropharyngeal muscles have to coordinate a swallow. Dysphagia treatments. Oral feeding. We can, like we showed on that ITSE level framework, modifications of diet consistency to help patients achieve a safe swallow. There's also non-oral feeding, but that's disadvantageous because you need to swallow to get better at swallowing. Positioning is key. I'll walk into patient rooms and they're laying down. That's not good for any of us, especially after we've had a stroke. There are compensatory strategies, and I want to say the key part here is these should be recommended by a speech therapist because one technique is not going to work for every patient. But patients can be educated on the chin tuck, which decreases the space between the base of the tongue and posterior pharyngeal wall, which increases pressure to move food through the pharyngeal region. And it also facilitates forward movement of the larynx, which helps prevent entry of liquid. Head rotation can close the ipsilateral pharynx, so you would turn your head to the paretic side. The head tilt uses gravity, and the supraglottic swallow is breath holding and swallowing, which closes the vocal cords to protect the trachea. We're working on oral and motor exercises to improve tongue and lip strength and motor control. Something that we think about is if a patient has been NPO for more than 2 weeks and has had to have an NG tube, that's when we want to consider a PEG tube. Post-stroke shoulder pain is very prevalent. 70 to 80% of those with hemiplegia will have varying degrees of shoulder pain. It's often noted during the spastic phase of recovery, but like I said, it's only often noted there. We can see it at any phase. It's associated with complex regional pain syndrome, rotator cuff tears, adhesive capsulitis, impingement syndrome, tendinitis, and possibly shoulder subluxations. Treatment for this post-stroke shoulder pain, positioning is key. So utilizing an arm trough or an arm board for patients that have less than grade 3 strength to that arm, or they just don't have, or they don't know where that arm is in its base. We like the arm trough or arm board. We also use humeral cuffs or slings with ambulation. We use K-tape and appropriate positioning in bed. Movement is also treatment for it. Promotion of early reactivation of shoulder musculature can help. And you might use functional electrical stimulation for that. We can also use pharmacologic intervention. So you are using your oral and topical medications, but then at some point they might need trigger point injections for myofascial pain, or they just might need a joint injection if they have some underlying arthritis as well. Visual spatial neglect is often seen in rehab. The patient has decreased attention to or is unaware of one side of their body. Of note, kind of visual spatial neglect is more commonly seen on that left side, and it is different than a visual field cut. Symptom examples would be this patient has a gaze preference. They're not turning their head to look left. They're eating only one side of their plate. They have an inability to localize the neglected side. And you might notice that because they only put one sleeve on when they're getting dressed. Just some interventions that anyone can do at the bedside, reminding family and friends to stand on the neglected side to talk to the patient, encouraging them to look. You might ask the patient to scan to the left side of their tray to find food, and therapists will work on visual scanning exercises, sensory stimulation, imagery, and they might use things such as prisms and patches as well. Post-stroke depression. It's estimated that up to 1/3 of patients with a recent stroke will experience depression at some point during their recovery process. And it's interesting to note that caregivers experience depression at similar rates to the patients. Their depression might be multifactorial in neurotransmitter depletion from the stroke and or the physical and personal losses following their stroke. While in the hospital, we can offer counseling, a chaplain if they so choose, pet therapy, visitors, outside passes. And then we can always start medications for this as well if needed. And SSRIs are the preferred medication. We're going to move on to spasticity. And spasticity is a velocity-dependent resistance of a muscle to passive stretch. It's resulting from that upper motor neuron lesion causing loss of descending inhibition on the spinal cord and reflex arc. And we notice it as that involuntary activation of muscle. And so we have increased muscle tone, exaggerated by tendon reflexes, clonus, and maybe some primitive reflexes as well. It's estimated that spasticity affects approximately 35% of stroke patients. There are pros and cons to spasticity. A couple benefits of spasticity is it might aid function. If you can kind of lock that leg out with tone, it might help them be safer in a transfer. It can also help to maintain some muscle mass. If we notice increase in spasticity, I might think that there's an underlying infection. And it also helps provide some DVT prevention because of those muscle contractions causing improved venous flow. Complications. In a transfer, the increased tone in a leg might help our transfer, but it might also make it a lot tougher. Or it might, if a patient is flexed at the elbow, it makes it really difficult to put a shirt on. It can also cause skin breakdown if they have their fingers in a flexed position and cutting into their palm. At times, if severe enough, it can cause bone fractures, joint subluxations, and eventually it can lead to some contractures, and it can be painful. What you'll notice in our notes is we'll grade spasticity, and we typically grade it with a modified Ashworth scale. A 0 is no spasticity. 1 is a catch and release and end range of motion. A 1+, I can move the arm, it's easily ranged, but I notice that there's a catch and resistance to movement for under half of the range of motion. At a 2, I'm starting to struggle to move this arm through full range of motion. A 3 means I'm putting effort into trying to extend them at the elbow if they have elbow flexor tone. A 4, the limb is now rigid. The spasticity treatment Pyramid is something I was taught in my residency program. And the thing that is most important for everyone is at the bottom of the pyramid. So we want to make sure that they're not in pain, they're positioned correctly, and we can remove some noxious stimuli. Then it is crucial that the patient is stretching, that therapists are stretching them, and that they're stretching them themselves. This is also, we're looking at bracing, positioning. They might even be casted. We can also use modalities such as vibration, which causes muscle fatigue as the muscles tire out. Or we might use e-stim, so stimulating until you fatigue the action potentials, overriding the other stimulus. We also have oral meds to treat spasticity. The FDA-approved medications are baclofen, diazepam, dantrolene, and tizanidine, and I typically try to avoid diazepam. We have botulism toxin. I tell patients they'll start to notice things maybe in 3 days, get a little looser. In 3 weeks, we really notice it. And in 3 months, it's wearing off. And it needs to be coupled with stretching and therapies. We can also do direct treatment or direct delivery of baclofen to the CSF, as you can see in this baclofen pump. And if spasticity has led to contracture, they can go to a surgeon for tendon lengthening, tendon transfers, and more. Aphasia. We notice the most recovery in the first 2 to 3 months for aphasia. Recovery does drop off after 6 months. It is noted that 19% of patients are estimated to have aphasia at the 6-month period. Key treatment for aphasia is practice, practice, practice. We want to start them early with speech therapy, and we want to start them intensely with speech therapy. Speech therapists are working with the patient with augmentative and alternative communication using pictures, communication boards and books, and body language and gestures. We can also use melodic intonation therapy. This is utilizing the right hemisphere for its role in incorporation of melodies or rhythms with simple statements. This is most useful if a patient has a Broca's aphasia. Constraint-induced aphasia therapy is also used. And then we have some pharmacologic treatments. However, no study has shown the unequivocal evidence that pharmacological therapy helps long-term. Medications that have been trialed in treatment of aphasia would be bromocriptine, amphetamines, donepezil, and memantine. We'll talk a little bit more about that one. Another key thing to ask is the patient depressed? Is it something where we can start something to help them be more alert, have a better mood, and maybe want to communicate more? Possible treatments in the future would be transcranial magnetic stimulation. Memantine, mechanism of action. This binds the NMDA receptors in an antagonistic action. Studies have found that upregulation of NMDA receptor function in areas of the brain where ischemic events have occurred. This causes an increase in glutamate, which can then result in increased calcium influx and death. Here's a study, memantine and constraint-induced aphasia therapy and chronic post-stroke aphasia, published in the Annals of Neurology in 2009. And so in this study, it was a randomized, double-blind, placebo-controlled parallel group of both memantine and constraint-induced aphasia therapy on chronic post-stroke aphasia. And they found that both memantine and constraint-induced therapy alone improved aphasia, but best outcomes were achieved when combining memantine with the constraint-induced therapy. And those effects lasted on long-term function. So I'm not going to cover all of these in detail, but other conditions that we are mindful of following a stroke would be DVTs. And these occur in about 20 to 75, so a large range of untreated stroke survivors. They occur in the affected extremity 60 to 75% of the time. And gosh, heterotopic ossification is so important. I guess I put it twice, but we can also notice development of HO. We can notice edema of the affected extremity because they're not moving it and contracting those muscles, and maybe due to positioning. We notice bladder dysfunction. Incidence in the first month after stroke is 50 to 70%, and 15% after 6 months. We can notice bowel dysfunction. This occurs in approximately 31% of survivors, but typically resolves within the first 2 weeks. Patients may also have seizures. They might have decreased attention and/or initiation. Sometimes we will use stimulants such as Ritalin to assist with that. These patients are at great risk for falls, and they're at risk for pressure sores if they are unable to reposition themselves. This would just be an example stroke plan. It wouldn't fit for every stroke patient, but it's just a guideline. So we're having every stroke patient work with physical therapy, occupational therapy, and speech therapy. For aphasia, we might consider the initiation of memantine. I typically wait at least a week so I know what their speech baseline is now before I start something. We're monitoring for tone. Like I said, we're trying to position them correctly with multipotency, Lennard's, resting hand splints, and then educating on stretching and positioning. Before I initiate baclofen, I'll often speak to therapists and the patient to see if the tone is helpful or if it's something that I do need to treat. For motor recovery, like we talked, you can add on an SSRI, but those subsequent studies have shown that it's not helpful for motor recovery. However, if a patient is depressed and hemiparetic on one side, I would have a lower threshold to start in hopes that it might do something. E-stim can also be ordered. I have the asterisk there for whatever extremity I want it on. Mood, we want to manage that or monitor that closely. For bladder, I like time voids while the patient is awake, and then we're closely monitoring PDRs to see if they're retaining. And then we have a daily bowel regimen in place. So when should PM&R be consulted? Anytime, really. But I see consults from the ICU or when they've been moved to the floor. And you want to consult us on patients who have had a stroke and they have functional impairments. And this is, my entire job is to determine if they should come to inpatient rehab. But we're looking at patients that won't be going home in the next couple of days, but they have the potential to improve. You can also consult us for patients that they had a stroke and they went home and then they started developing tone, or they noticed that they had continued impairments in their function. We would love to see them in clinic and start managing their spasticity or see if there's anything else that we can do to help improve their function and their safety, because all of this leads to improved quality of life. So those are my references. I know I kind of went fast at the end here, but yeah, if there's any questions, I can answer those. Otherwise, we can be done.
So we had a hand raised earlier. Ellie Schmidt, did you still have a question or comment? The hand is unraised now, but go ahead and raise it again if you still had a question. And anyone else, feel free to type in the chat or raise your hand if you have any questions for Dr. Madson.
Okay.
I'm not seeing anything on my side. So we can give people time back in their day if there's nothing else that's coming through. And then Dr. Madson, if any questions come our way, afterwards, I'll send them over. And any of you guys can feel free to contact us. I realize I didn't, you have our contact from the sheet that has the information about the webinars. So feel free to email Joni or I, and we can shoot those questions back to Dr. Madson or connect you guys as well. So if that's it, I think we can end there unless Dr. Madson, you have anything else you want to add or?
No, that is all. Thank you.
Thank you so much. This was a great presentation. I think it's always helpful to see that kind of what you're doing and then the rehab side of things. I think often when we're in acute hospitals and settings, we kind of do the patching up and getting patients healthy and safe, and then they kind of leave and sometimes we wonder what's going on afterwards. So it's nice to see that kind of wrap up side of things for everyone to understand that more.
Well, wonderful. Well, I hope I did the speech therapy portion justice as you
You
are
did.
a speech therapist.
You did. That was great. Yeah. Yeah. I like the use
Okay.
of ITSE. It sees the new standard across the world. So it's nice when we see facilities using that so that there's equal communication and so everyone knows what we mean when we're talking about that. So great job on that.
Absolutely. Thank you. Bye-bye.
You're welcome. All right. Thanks, everyone.